Good afternoon, everyone. My name is Omar Abu Madawy. I'm a fourth-year resident at the Ophthalmology Department of Alexandria University. And today I will be talking about Antarctica. It all started during my second year of residency when I met this 18-year-old boy whom we diagnosed with iridocorneal endothelial syndrome, or as we all call ICE. I asked myself lots of questions back then. I chose the name Antarctica because whenever we think of this continent, we think of ice. So does my presentation, because I'm not only one case of ice, but two of them. I was lucky enough to encounter a 70-year-old male who presented to our clinic with OD, progressive diminution of vision, during the previous 2 years. He has free ocular, medical, and surgical history apart from BPH-1 treatment. He had a best-corrected visual acuity of 0.16. His hyperope and the left eye examination is unremarkable. Upon examination of the anterior segment, the right eye showed beaten bronze appearance of the corneal endothelium, a broad-based peripheral anterior synecdoche, particularly inferiorly between 5 and 7 o'clock, correctopia, ectropin UV, and a nuclear cataract grade 2. Here we can see an image of the right eye showing the correctopia, the ectropin UV, the peripheral anterior synecdoche, and on the other side we will see a high mag of the beaten bronze appearance of the corneal endothelium. I started my work up. To start with, the IOL master has showed an AC depth of 2.82, which is expected regarding his refraction, his hyperope. And the specular microscopy has showed the light-dark reversal pattern, which is characteristic for ice cases, loss of hexagonality, and pleomorphism. This is the first specular microscopy. It showed a cell density of 2,264, and I was a little bit skeptical about this endothelial density given my examination. I really expected a much lower count. So at that time, I decided to resort for the AI. The AI astonishingly was able to create an enhanced image from the original image produced, detect the cell-like structures, choose a clear area in order to detect the cell boundaries, and then produce a totally different count. As we all remember, the specular microscopy has produced 2,200. The AI has given me a 781, which is extremely different and a game changer in the management of the patient. The nerve fiber layer has showed mild infratemporal thinning, normal OCT macula. At the first glance of the perimetry, we might think that this patient is glaucomatous with secondary glaucoma and a tubular visual field defect, but let's take a look at the refraction. His hyperope wearing his hyperopic correction, restricting his visual field, so this is the classical rim defect, and the patient's examination, nerve fiber layer, and perimetry are normal. These are the surgical planning for anybody planning to do phaco in ice syndrome. The first difficulty that I faced is the shallow AC, IFAS state, and the possibility of forming of peripheral anterior synecdoche and secondary glaucoma. So I decided to do clear corneal, very long tunneled incisions. Secondly, the use of a preservative-free trypan blue. Trypan blue is a must when doing phaco in ice cases. Endothelial cells have the ability to migrate to the AC, causing secondary glaucoma, and it has been reported that they migrate to the anterior lens capsule with the creation of a pseudocapsule. And the only way to differentiate between them is the preservative-free trypan blue. Definitely preservative-free in order to save as much endothelial cells as you can. Thirdly, copious OVD, continuous curvilinear capsular access, and definitely a double shell. Cohesive and mainly dispersive are your best friends. I decided to do the continuous curvilinear capsular access after reviewal of the literature, exactly as the same size of the pupil. I know it is not the biggest pupil, but I can proceed with phaco from that side. It's around 4.5 to 5 millimeters. The use of expansion devices such as iris hooks, as well as Malugin rings, have been proven to increase the post-operative inflammation and the IOP by 10 millimeters mercury. This is my first obstacle. The second obstacle are the use of iris hooks itself, particularly in ice syndrome cases where the iris is atrophic, might even make it worse and lead to iris damage. So I decided to proceed with my phaco without them. As I mentioned, the keywords are copious OVD and definitely chopping. Vertical chopping is preferred due to the small-sized pupil, as well as horizontal chopping, so that the end result are minute phaco fragments that are easily aspirated with the least amount of phaco power possible in order to save as much endothelial cells as you can. This is the end result at the time post-operatively, an IOL in place. And this is 1 week post-op, clear cornea. We can see here more evidently the correctopia, IOL in place, and the patient's best corrected visual acuity is 0.5. I was very interested to know the effect of my techniques and how much endothelial cells are lost in ice cases. So I did a specular microscope around 3 months post-op. It showed a cell density of 689. Given the result produced by the AI, this is very acceptable. And again, I was very interested whether phaco will accelerate this progression of the endothelial cell loss. We can take a look at the date. This is in May 2024. This is in June 2025, and we have more or less the same endothelial cell count, the same hexagonality, the same coefficients of variation. The central corneal thickness is a very important remarker here because of the progression of corneal decompensation. Thank you so much.